everyone, and welcome to another segment of SDOH Field Guide presented by Advocate Advisors. I'm Michael Sattler. The social determinants of health are being discussed everywhere right now, but there are a lot of people who have questions about exactly what that means and what to do about it. The Field Guide is a starting point for people to get quickly up to speed on social determinants of health. So if you have a question about SDOH to which you'd like to see a no-nonsense answer on camera, tweet it to @SDOH Field Guide. Now, in past segments, we've looked at the major components of social intervention programs. If you haven't watched our overview, I'd suggest doing that before watching this segment. Today, we're going to focus on the second element of social intervention programs, assessments. Also called screening, assessment is essentially an answer to the question, how are social needs assessed for an individual? The idea is that once an individual is engaged with our program, we have to figure out what they need in order to help them. Now, the degree of sophistication in assessment varies from informal to formal to very structured. We'll cover each of those in more detail. Now, the first kinds of needs assessment is an informal one. Some programs are just open to the public, and they invite a care recipient to search for a service that they need and select a program that offers that service from a menu. So, for example, if I needed to find a local food pantry near my home in Hartford, Connecticut, I might go to the local 211 website, enter in food pantry, and select a provider that offers that particular service. Maybe I call the number on the screen, or I print the information for use later. Now, this process is sometimes known as a seeker-driven model, and from the search terms entered or the program I selected, the social need that I might have can be inferred. Now, for those programs that offer an intermediary, a healthcare provider or a community health advocate or a phone operator at a 211 service, the social needs assessment happens as part of a conversation or a discussion with the care recipient. Now, in some cases, the need is not even really documented, just the program or the provider selected to help address it. Now, there's nothing wrong with informal assessments. Informality can make the assessment process less intimidating and more accessible to care recipients, which is actually a really big deal. But it can also result in needs being missed. Online searches and self-assessment sometimes make it difficult to get a broad sense of someone's needs or the way they relate to each other. With web-based systems, the quality of the interface and the available data can often make a big difference in whether one gets an accurate picture of a care recipient's needs, not to mention how willing they might be to trust their data to a computer. When a human being is involved, the outcome often comes down to the level of skill of the interviewer and the trust that the recipient has in that person. After all, sometimes revealing your social needs can be emotionally difficult to admit. Finally, informal needs assessments make it trickier to do consistent evaluation and analysis of a program as a whole. Since each assessment is effectively subjective, comparing assessments to one another or across a program can be tricky and muddy the results. Which brings us to formal assessments. Now, formal assessments are lifted from healthcare's traditional diagnosis practice related to EMRs, which involves a trained clinician selecting options from a menu and coding them into a patient's record. After all, clinicians are required to categorize medical diagnoses in the EMR. Why not do the same thing with social diagnoses? So naturally, there are predefined code standards for social needs that track them in the same way that medical diagnoses are tracked. At the highest level, formal standards exist for diagnosing social need categories or domains of care by using a set of LOINC codes. I love saying LOINC codes. LOINC stands for Logical Observation Identifiers, Names, and Codes. LOINC. So, for example, a recipient who indicated housing insecurity would be tagged with LOINC code 71802-3, and if they were homeless, they'd receive the answer LA 18835-1. Now, there's a parallel standard called Snomed Codes. Snomed Codes, which stands for Systematized Nomenclature of Medicine and works in a very similar way. One level of detail down are diagnostic codes for specific social needs. One good example here are ICD10 Codes, which stands for the International Statistical Classification of Diseases and Related Health Problems, 10th revision. So, for example, if a clinician diagnosed a patient as homeless at the time of their visit, they'd receive a Y for yes under ICD10 code Z59.0, which is why these codes are sometimes called Z codes. Now, If all that sounds complicated, it is. And these are just the most common coding systems. There are plenty more other systems, and they don't always agree with each other or even think about the causes and domains in the same way. So to help sort this out, the US government has put together an Office of National Coordinator for Health Information Technology, usually called the ONC, and they've set some standards for coding social diagnoses around SDOH and treatments, etc. They certify certain systems that conform to those standards. As of this writing of this video, 72 health IT developers have certified 93 separate products using the ONC standards, which results in roughly half of all office-based clinicians and about 1/3 of all hospitals. The rest are making things up on their own. Now, the upside of formal coding diagnoses is, of course, consistency. Theoretically, this means that the same social diagnosis done by anyone anywhere gets the same code, so you can compare and report on things in the same way regardless of where they took place. Now, it's also the way insurance companies and other payers track and pay for the services involved, which is ultimately critical to how they're actually delivered. But that leads to the really tricky part. In healthcare, payers rely on standard codes for diagnoses, which in turn lead to standard procedures to address those diagnoses, which sounds perfectly logical. In fact, there's another whole set of codes called CPT Codes, which stands for Current Procedural Terminology. And these correspond to procedures designed to treat diagnoses. The problem is that social determinants of health behave quite differently from traditional medicine. In the medical world, diagnoses can generally be confirmed by conducting scientifically validatable tests. You can test someone's blood in a lab to establish if they have E. coli. But you can't do a blood test to find the cause of someone's homelessness. Worse, the procedures that might help address someone's homelessness can't easily be narrowed down to a finite list of scientifically proven and repeatable procedures, like a course of drugs or a certain kind of surgery. Not only are social conditions complex when it comes to these kinds of problems, but they're based on a host of subjective factors: culture, language, personality, educational background, environment. And the procedures that work in one place under one set of these conditions may not work at all in another place under another set. And finally, the specialists being asked to code their procedures in this way, in this case, aren't doctors. They're nonprofits and community-based organizations and agencies. What they do doesn't quite fit into this methodology, and they're not used to these kinds of systems. Plus, most of them aren't used to being reimbursed for procedures like doctors are. They pay for their services out of fundraising and donations and grants, not on a fee-for-service kind of basis. This disconnect is generally referred to as the medicalization of social services, and needless to say, it's a significant wrinkle in putting these kinds of programs together. But some very smart people are involved in sorting this problem out, specifically establishing standards for linking EMR systems with providers who take care of social needs. The Gravity Project contains representatives from all the major names that you'd expect in healthcare, and they're kind of one of the leading examples, but there are others out there as well. Now, the third way social needs assessments are often done is what we call structured assessments. These are really questionnaires that are purpose-built for social needs screening and try to balance the need for structured data with the need for informality of exchange. And there are plenty of these questionnaires out there. A useful comparison chart for some of the better-known screening tools was put together recently by a group called the Siren Network, and we'll include a link to their analysis in the comments section of the video. All these questionnaires try to ask the fewest number of questions to cover the highest number of possible social needs domains. One of the leading assessments is called PREPARE, which stands for the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. The PREPARE has 17 questions covering 12 social domains and is provided by the National Association for Community Health Centers. It's generally regarded as the emerging standard for broad-stroke social determinants assessments. But in addition to assessments like these, there are a wealth of structured assessments for specific social need categories like childhood trauma or behavioral health or homelessness. There are also a wealth of state and provider mandated assessments that certain organizations insist upon using as part of their programs. For example, the state of Hawaii mandates a 500 question assessment to be completed for each of its Medicaid enrollees every 6 months. Now, the upside of structured assessments is that they're a thoughtful balance between the open-ended, informal interactions that are often typical in SDOH screening and the need for structured, consistent coding that EMRs and healthcare payers want to see. One extremely important thing to keep in mind is to be aware of how the assessment and screening process might be received by different communities of care recipients. Language and literacy levels, cultural knowledge, the levels of stigma involved with social needs, and most importantly, the level of trust between the recipient of care and the assessor or the program, all can have a huge impact on the assessment process, which can in turn result in inequities in how care is actually delivered to the people who need it. There's a whole field dedicated to health equity around this particular topic, which we can cover later. So the big takeaway is this. Whether a program chooses informal, formal, or structured assessments, it's important that care recipients get their needs assessed consistently and recorded in such a way that they can be tracked and matched to specialists who can meet those particular needs. And that should do it for this segment. Thanks very much for watching. If you have a question you'd like answered on camera, please tweet it to @SDOH Field Guide. I'm Michael Sattler from Advocate Advisors. Thanks very much.